we'll start with Larry Lowe, who's going to talk to us about how to stay out of trouble when working up spine tumors and unknown lesions.
All right, thanks, Matt, for the introduction. Again, thanks to Katie and Matt for the invitation. So I'll be talking about sort of like the basics in terms of how to manage an unknown lesion that shows up in the office or in the emergency room. These are my disclosures. They're not particularly relevant to this talk. Um, so let's just say that something like this shows up in your clinic and the patient has back pain, essentially, which is how this patient presented. And you see this gnarly tumor, and the guy's actually walking into your office without any neurological deficits. And I think, at least for me, I think the first thing I always tell myself, and this is what it looks like on a CAT scan, I think the first thing I usually tell myself is sort of take a deep breath, if you will. I think that it's very often to be like, oh, wow, this is like a gnarly tumor, or we can be overwhelmed. And I think that if we keep it to the basics, I do think that it keeps us out of trouble. And these rules are from sort of a slide deck that Matt had shared with me, but I used a lot of it because I think it's some terrific concepts. And basically, I think the number one thing that keeps you out of trouble is getting a good diagnosis. I think that oftentimes, at least in my practice early on, you'll be overwhelmed by the imaging findings such that you forget about the basics in terms of doing like a good HMP to try to discern whether could this be a primary tumor based off of the history and the age? Could this be a MET? Could this be a myeloma, lymphoma, plasmacytoma, or even an infection if the guy's like an IV drug user? So I do think that it's easy to overlook, but it's important to still sort of keep it to our basics as physicians and do a good HMP. Obviously, labs can be tremendously helpful. If the guy has a history of prostate cancer, then it takes very little time to send off a PSA to see if it's sky high and could the lesion be essentially a metastatic prostate cancer presenting for the first time. Imaging wise, I think we're always focused on the spine, right? As spine surgeons, I think we tend to be myopic and we kind of want to get spinal imaging. And obviously, there's no issue getting a full spinal column MRI. But I do think that one thing that sometimes gets overlooked is getting staging scans, right? To see what the disease burden is. And I think that in the emergency room setting, obviously, I think it's not practical to do a PET scan as an inpatient, but certainly I don't think it takes too much effort in most emergency rooms or inpatient settings to do a CT chest, abdomen, pelvis with IV contrast. And I think that certainly, at least that's a dirty and quick way to understand what the disease burden is. And I think that you want to be careful when that staging scan shows that it's a solitary lesion. And the reason why is, as a spine surgeon, most likely we are encountering a metastatic lesion, right? That is by far the most common type of spine tumor. And I'm sure most of you are familiar with this slide, but if not, this is sort of the NOMS paradigm based off of neurological, oncological, mechanical stability, and systemic treatment and status that kind of determines how we manage metastatic spine disease that was pioneered by Ilya Laufer and Mark Bilski and Memorial Sloan Kettering. And this is, for the most part, sort of a broad framework of how we approach metastatic tumors. On the other hand, if it's a solitary tumor and it ends up being a primary, it's a very different set of considerations on whether could the patient tolerate an attempted curative resection, how resistant is the pathology to alternative treatment methods, and you have to weigh that against the morbidity of surgery to see whether we would actually do an attempted curative resection. So from the get-go, the way we think about these tumors are fundamentally different. So I do think that it's important to take a step back and try to get that diagnosis of what it is. And oftentimes, this requires a biopsy. For example, if the HMP, the imaging tests are not coming to a sort of a conclusive conclusion. And I do think that we've probably moved away from the days of the spine surgeon doing like an open biopsy. I do think that that is sometimes still done, depending on the capabilities of the interventional radiologist as well as the pathology team. But for the most part, I would say that a CT-guided biopsy is generally preferred over an open biopsies. Um, but the key is that it's open communication with the IR team. You want to talk with the IR team about what approach are you using. If they have to drill through bone to make sure that they're not spreading the bone dust through the entire biopsy tract, a coaxial technique to prevent spillage of the tumor. And for example, if you're suspecting infection and you don't relay that to the interventional radiologist, they're not going to send cultures. So I do think that this open communication is very key to get a good diagnosis. I think the second thing that's important ultimately, and particularly as it pertains to metastatic spine disease, is understanding the prognosis. Again, oftentimes, like we encounter the patients, especially for metastatic spine disease, when they're having problems, whether it's mechanical back pain, neurological issues, or if there's a radiographic finding of a pathological burst fracture or something like that. But it's really hard to treat the patient in terms of making specifically a surgical recommendation if you don't really understand the trajectory of their disease. Are they just newly castration resistant in the setting of having metastatic prostate cancer that's been hormonally responsive for like years? Or are they really on their fourth or fifth line systemic treatment and they're enrolled in clinical trials? And I think that understanding the trajectory of disease and their expected survival, as well as their wishes, are quite important to make a good decision about how to treat that. And one thing that comes to mind is that this is quite an interesting study that was performed by the Scalar Oncology Research Group as well as the Dutch Spine Society. And basically, they looked at, are surgeons any good at predicting survival for metastatic spine disease? And they basically polled 60 surgeons. They showed 12 cases with actual survival ranging between 1 to 73 months. And they asked each of the surgeons life expectancy and recommended treatment. And they had a nice spread of orthopedic surgeons, neurosurgeons, various degrees in terms of their career. And if you look, essentially, there was no agreement amongst anything. And perhaps most importantly, for the patients where the actual survival was quite poor, we tended to overestimate, sometimes by like years. The y-axis here is actually months. All right. So we were quite off in predicting how long the patient was going to live. And vice versa, for the patients where the actual survival was quite long, like multiple years, we tended to underestimate their survival. And the key is that the recommendations obviously were based off of what the surgeon perception of their expected survival was. So for the patients where at least a surgeon thought that they're going to live 12 months or more, even a small cohort of the surgeons recommended like an en bloc spondylectomy to address their spine disease. So it's quite important to accurately prognosticate. And I do think that we have much better prognostication tools now. This is kind of already old now, but this is from Joe Schwartz's group, from the Scalar Oncology Research Group. And this is sort of the first iteration of the nomogram before the machine learning algorithms. And this was validated with an external data set showing that this performed quite well in terms of the area under the curve compared to like the Tokuhashi score or other scores such as the Tomita score. And there's been better iterations of that based off of stochastic gradient booting and machine learning algorithms that have predicted 90-day survival, 6-week survival, and even 1 year survival. And these tools, once you get a hang of it, are very easy to use. The first 3, 4 times is very tedious in terms of, oh, like I have to plug in like an Alpi bin, I have to group the tumor pathology into a specific category. But once you do it a couple of times, I think it comes much quicker. So I do at our institution, I do ask our residents and our fellows to kind of already have done that before they even call me for metastatic spine disease. And I think that that's something that at least certainly better than the surgeon just guessing based off of a gestalt, if you will. And sort of like the final rule, I think, for me that sort of at least keeps me out of trouble is don't rush into surgery. I think if you're lucky to be at an institution or a setup where there is already a multidisciplinary team to discuss how to manage a newly diagnosed lesion, I think that's critical, right? And each of the different specialties do really bring something valuable, right? The radiation oncologist is going to tell you, hey, for that plasmacytoma, although there's ESCC grade 3, sort of high grade caudate equine cord compression, it's like we're going to likely see quick macroscopic reduction in the epithelial disease by just radiation alone. Your interventional neuroradiologist might tell you that, hey, instead of doing like a fixation for that, I can actually do a spine jack to stabilize that pathological fracture or do a tumor ablation for local control. Your oncologist might weigh in on, oh, actually the prognosis for that patient is going to be quite good because there's actually actionable targets on a foundation testing. And they might even tell you like, oh, I've definitely had, like, I didn't even realize what are the brand names of the TKI was. They told me, oh, this patient's on a TKI right now. So they're going to have wound healing problems. You might want to get plastics involved, even though you're anticipating a small surgery. And even your fellow surgeons, right? Your fellow colleagues, they might be like, oh, that's actually a solitary fibrous tumor, and we're expecting a lot of bleeding. And so you would consider preoperative embolization. So I do think that if you present these cases to your colleagues, and ideally sort of if there already is a setup to discuss the cases multidisciplinary, then I think that's quite helpful. I think by this point, I think at least most spine surgeons are probably familiar with like the SIN score, and it's created sort of this language that we can use amongst surgeons, radiologists, radiation oncologists to kind of talk about how unstable a lesion is. But what I've seen more recently is that because it's so widespread, that a high SIN score, I do have seen scenarios where it translates into like a surgical emergency. And I do think that that's something that potentially is a cause for sort of poorly managed spine tumors, because I do think that fundamentally, like a de novo kyphosis or like a subluxation in a tumor patient is very, very different than a fracture subluxation in a trauma patient, right? The trauma patient developed that and it's a true three-column injury, and the spine is grossly unstable to the point where if you're going to get an MRI, you even worry about that MRI, transport gene MRI hurting the patient. For a tumor patient, that change is glacial. So yes, a high SIN score would suggest that certainly surgery should be considered for mechanical stabilization, but it doesn't necessarily mean that you have to do it the night they present to your hospital or the next day, right? I still think the odds are that waiting a couple of days to kind of get the previous workup done really won't affect things. So I do think that that's something that is important to know is that now there's a separate talk talking about true emergencies in terms of neurological problems, and it's a separate story, but a high SIN score doesn't necessarily portend to sort of emergency surgery. So ultimately, in terms of like the key take-home messages for me is that I do think that ultimately the patient is much better off, and you are better off if you're able to obtain a diagnosis before you treat. Ideally, make an effort to understand the prognosis as best you can. And finally, there's no reason to treat every tumor like it's a surgical emergency. Ideally, come up with a comprehensive treatment plan from talking with others and talking with a multidisciplinary team if there's one already available at your institution. Mhm.
Larry, that was phenomenal. Thank you. I, we have three other fantastic talks and only a little over an hour to do this. So I want to move on to the next talk. But before we do that case you showed, that very, very scary sort
Oh,
of
perfect. Yeah.
uh, L5 lesion,
Right.
high grade stenosis, obviously an aggressive process that's destroying the L5 bone, but also all over the retroperitoneum and all over the paraspinal muscles. So there are some people that advocate for like almost not biopsying some chordomas. I think this isn't necessarily obviously a chordoma, so maybe not applicable to this case, but we worry about seeding with biopsy. And so how do you get the cleanest possible biopsy when this thing walks into your office?
I think the key there is, like I said, the communication with the intervention radiologist. We will actually go over the plan trajectory for this. So for this patient, the plan trajectory was basically midline, immediately adjacent to the spinous process on the left. And basically, that biopsy tract was incorporated into the surgery in terms of the skin resection. But I do think that ultimately that's overkill. I think that our interventional radiologist keeps on telling us that, with these modern instruments that they have in terms of these coaxial guides and sort of sheath guards, that the chances of tumor spillage are minimal at this point. And they even feel comfortable passing in sort of power instruments to drill through bone, and they feel very strongly that they're not contaminating the biopsy tract. I don't know if I buy that, but I do think that we've come a long ways in terms of like a Craig needle biopsy and like trying to make sure that you don't shake off that little tumor at the end as it comes out of the biopsy tract. So I do think that probably the more modern techniques, you're less likely to see the tumor. I think the key is that when it's sort of like a low-grade tumor, and like I would say if anywhere we biopsy for this probably was going to show that this was a chordoma. But in cases where there's like a heterogeneous appearance on an MRI and you're worried about, let's just say that you're worried about a chondrosarcoma, right? And there's an area that looks like avidly contrast enhancing with areas of necrosis, then you're going to want to target that because that part might come back as grade 2 or grade 3 rather than a chip shot that's right on the surface coming back as grade 1, which would affect your management. So, like I said, I think that you obviously want to talk with your intervention radiologist for them to do that. Because, like I said, if they're biopsying for a MET, then they might not actually do all those things. So I think, like I said, getting this on their radar that you want a clean biopsy and even specifying like how you want the trajectory to be or what area you want is going to be pretty critical.
I want to just ask the panel a follow-up question on biopsy. So obviously not in a situation like this, but when you have a more subtle tumor that's in the vertebral body and you order an IR transpedicular biopsy and it comes back as an air ball, it comes back as normal tissue or non-diagnostic tissue, what do you do? Do you have any particular moves? Do you send them back for a second biopsy? Do you biopsy it yourself? How do you handle that? Pretty common situation.
I haven't thought about that. I would say uh, oftentimes, or not always, not often, but we'd get outside hospital or whatever sent in the patient with a non-diagnostic. Typically, I would repeat it once, negative. Second time, review with the interventional radiologist. Hey, this looks more lesion there. It looks like this is a necrotic area. This is a bony area. Maybe we could target, you know, area X, higher yield. And then typically, if those two are negative, third time we go for Craig needle open biopsy. Try to get better core tissue. But I think it often will depend on the context of the case. Patient's asymptomatic. It's a vertebral body lesion with minimal epidural extension or no compression, no neurology. I think you have more time to play with. I think obviously in the context of any sort of neurology, uh, less room to get repeat biopsies
Right.
in that case.
I think I agree with that. I think communication, like always, is really paramount, and not just in the patient with neoplastic disease, but infection also. When perhaps you might want the disc biopsy, but they get more of a bone biopsy has happened to me before. But communication with the IR staff and perhaps repeating it with some additional information from the surgeon is very helpful.